were talking about the professionalism of the report. You started down how long to how long to assess these various things. So let's talk about the brand new provider, right? So I mean, I remember early in my career, my first call, I'm looking at the same guy that I just graduated EMT school with, and we're like, yeah, we got to figure this out, right? We got to figure this out. We've got nobody to, it was a small volunteer department. I mean, we had what we had, right? And so how do we drive this line where we walk in, we think it's DOA, but we want to err on the side of the patient? Triggers to start resuscitation on that. To start resuscitation before we make a turn and say, nah, this isn't. I mean, obvious death is easy, right? With liquefaction and stuff like John was talking about earlier. But let's just say we have a cold modeled body, right? Do we, apneic patient, that new provider, right? So I'm going to walk in with years of experience and just fundamentally feel it out, right? We're all going to do the same thing, right? That's easier for us because we've been in that situation and we've probably been on both sides of that. But
I've never been on the dead side.
Indeed,
I've been close. I've tried.
Yeah, you tried, right? But but for that new provider, they're walking into it the first time. To resuscitate, not to resuscitate, just this cold, dead apneic, patient. Probably DOA, but they're not sure. They don't
Honestly,
know.
Scott, I think when in doubt, start a resuscitation.
Yeah.
I think that if it isn't frankly obvious with the things that we've listed in our protocol pretty succinctly, you should be resuscitating that patient. And that patient that is, in a veteran's eyes, obviously dead, is going to be dead. Nothing's going to change that. And that person is going to get the opportunity to work a resuscitation, to go through the process. If they're a paramedic, in the old days, before COVID, I call that the old days now because it's 4 years.
Because it was 4 years ago.
I mean, we had a very robust evaluation, which included, for ACLS standards, the same BLS standards, right? Mm-hmm. Am I going off too much here?
No.
I was intentionally setting that stage to transition to the BLS termination.
Right, because they both had this criteria, the three primary criteria. Unwitnessed by EMS, non-shockable at any time, and no ROSC within 20 minutes of a resuscitative effort, whether it's a BLS or an ALS effort. And meeting those three criteria is a 99% morbidity mortality. You're done. Mm-hmm. Yes. And the thing is 1% or less is considered a futile effort. So that really stood the test for BLS requirements. And we adopted those because of COVID and how dangerous COVID was when it first started. Certainly we have different attitudes about COVID, but that's a whole different topic. When we're talking about ALS, we included capnography less than 10 for 20 minutes. You know how difficult that is?
As a mandate,
Yeah, as a mandate.
Right.
When you put a Lucas on somebody, some of these folks that are using ITDs, I mean, you're not going to get to 10 when you've got profoundly advanced perfusion devices, But that was part of the criteria, advanced airway, advanced access, 2 rounds of drugs. So we would go through all these ALS standards and find it difficult to actually terminate somebody. If they met all those criteria, it was 100% fatal. Right. Okay? So you got your futile 1% added. So we've moved the needle, and we're quite satisfied with standing our BLS standards, which I'll just be a little redundant and go over it one more time. Not witnessed by EMS, non-shockable rhythm, and no ROSC for 20 minutes of a resuscitation. So to go back to your original question, if you're not sure, give them that 20 minutes.
Give them that 20 minutes.
And then when you make that professional phone call to the medical directors, we are very convinced
Right.
that person's time of death is such and such.
Right.
And God rest their soul.
Now let's pair that off a little bit, because we have not done away with the ALS field termination requirements either, right? They still exist.
They exist, but we really follow the BLS standards.
Yeah, for somebody in that found down.
Right.
Now let's pair this off maybe in another found down, unresponsive, apneic, pulseless, close to the DOA protocol. Let's pair this off. I have somebody, and now I've got some VFib, or I've got something else on the monitor.
Okay.
Now, does that BLS still apply?
Well, not if you're dealing with advanced.
Let's not use VFib. That's a bad example. PEA. Because VFib's shockable, and it would automatically throw the BLS right out, right? So let's say it's let's just say it's PEA, right? I've got a wide complex idioventricular, ugly, nasty rhythm on the monitor. All right, so we start full-blown ACLS resuscitation on this patient, right? How then do we pair that off? Do we then have to hit all of those ALS things now that we've engaged that patient, or is this something that I can be like, nah, well, it's idioventricular.
I have my thoughts, but
I think you work them.
Yeah.
I'm actually with you 100%
H's and
on this.
T's.
Yeah.
Yeah.
You got to go through H's and T's. And we've all had cases where everything happens just right. Recently, I had a case where witnessed arrest in a place of business. Patient hit the ground, CPR started, AED applied, shock. Fire department there in 2 minutes. They shocked. They gave drugs. They intubated. They brought the patient to me. Mm-hmm. I heard this story. I'm like, I can get this guy back, right?
Right.
He didn't have time.
This is the one that lives.
This is the one that lives.
Yeah,
right?
yeah, right.
This is the one that I give thrombolytics to, and then I worked for him for an hour and 15 minutes from his downtime. But
you certainly gave the thrombolytics an opportunity.
We gave the thrombolytics an opportunity to work. We gave those
a lot of
medications.
people don't.
No, not
and we watched him progress from refractory VFib all the way through asystole by the time we called him.
Okay.
So this gentleman had every opportunity to live. Everything happened exactly right. Bystanders did what they did. Everyone was trained on AEDs at the place of business. They did everything right. Fire department did everything right. We did everything right in the emergency department, and we just couldn't get him back. Yeah. So there's those times you just can't get him back. Yeah. So those happen, but we want to be able to save the people we can save. So if it is an odd rhythm, you have to give all your effort there. You have to work the whole thing through, and if they do progress to asystole during that time, that's one thing. But maybe it stays refractory VFib. Maybe you give all your medications, and maybe you call us and we say, yeah, you're going to do this. You're going to bring them to us, and we're going to actually keep working them because they do have a chance to survive.
And John, I think it goes back to exactly Scott's original question. You're not sure, is it a DOA? Give them an opportunity.
Do the thing, yeah. Do the thing.
Yeah. But I think also realizing when you show up on scene that a 90-year-old that's found down is different than a 30-year-old found down. So in this case, it's a young female, I think 30s or 40s. That's someone you absolutely do everything for.
Sure.
Little bit different than you walk into a room found down and a 90-year-old person, history of cancer, right? That you go.
That sounds like a moment to plug ECMO.
Well, and then there's that too, and then you have choices of, if you're lucky enough to have an ECMO center within your region of transportation choices, right? You're going to maybe take the 90-year-old to the local center, a 30-year-old that's in refractory VFib. Right. You should spend the extra time transferring to an ECMO center.
To an ECMO center, right?
I mean, and one of the sad things about ECMO is it's not everywhere, and it's going to be hard for us to transport a patient out in a cardiac arrest to an ECMO center. We do it. We have a protocol for it. It's very selective, but if you want to make sure that patient gets the best care, take them to the highest level of center.
But you want to talk about everything having to go just right.
Absolutely.
Yes. To get them moved.
Yep.
Is tough.
But if you notice, they go if you're there and they have witnessed cardiac arrest, even by bystanders with immediate bystander CPR, that's the person that you go all out for, right?
Sure.
Yeah.
And I guess let's frame up why that response came out of your mouths the way it did. And that's in our system. We do have an eCPR system,
Yes.
right? But that is really centralized around our hub. So, the catchment area is for eCPR is basically a circle around University Hospital's main campus in Cleveland, right? And we're asking all of those departments in those refractory cases or those minimize on-scene time if they're candidate for eCPR and get them downtown to
which is just the opposite of what we train our providers for.
Correct.
Then you go outside of that ring and a different set of, I don't want to say standards, but a different set of rules apply because we don't have that early eCPR access, right? So we don't have to have that extra layer of differentiation on, is this the one I stay on scene for?
Right.
Correct. Versus move.
Right, because
Yes.
versus move, and I think that could be its own. Could be its own entire.
It probably
probably will.
We definitely have to do that.
That's going to be its own piece, right?
Yeah.
Back to this.
But I think a lot of this is whether it's like resuscitate, not resuscitate, where to transport, what should you do for your patient. I think it's really simple. Whether you're a basic, advanced paramedic, even physician, NP, PA, nurse, MA, doesn't matter what your certification level is. Treat that patient like it's your own family.
Would you do this to your family?
Amen.
Exactly.
Yep. Would I want my family member who is a young patient have every opportunity to survive this? Yes. Well, then do that, right?
And let's talk, since you brought up family, this will be a good segue into family a little bit. I'll go down the specific DOA route. So we come in, we do all the proper things, make the notification to the ER physician, we get time of death. Now our EMS providers are probably dealing with hysterical family. They're obviously very emotional, tensions are very high, their loved one has just passed away, and sometimes that can be very hard to manage with those family members, and everyone reacts differently. And I think that's something we probably don't talk about enough, is how to properly manage that. And then how do we also communicate with the family, right?
So, a couple of things. Number one is there was a research project, and it's probably 10 years old now. Because when we started this whole field termination, and Scott was involved with this, we really needed to know, are the pre-hospital providers qualified to do this?
Right.
Okay? And the research pans out that if you're there doing a resuscitation, showing empathy and professionalism, that the pre-hospital providers are actually better equipped than that single emergency physician who's running around and pops into a room, tries to be empathetic, but you can only sell empathy so far when you have a whole 60 seconds,
Yeah.
And it's been shown that the pre-hospital providers are more than equipped. They just need to do what they do best, which is show your empathy, show that you care. And, something I do in the emergency department almost routinely when I'm doing a resuscitation, if there's family, I actually bring them into the room.
Want to watch. Yep.
Because the process of letting go starts with realizing that this is truly happening.
Correct.
And our providers who are trained, and we talk about this all the time, when you're doing a field termination, let the family see what you're doing. Talk to the family. Tell them what you're thinking. And then when those criteria are met, you're going to have caring. You might get hugs, but whatever's happening is going to be so much better than just dragging them to a hospital when there's no hope, and having them sit there and wait for an ER doctor who can only spend a minute or two with a family.
I remember that. I actually remember you put that presentation together.
Yes.
When we taught that. That's been, 2, 3, maybe even longer years ago. It's been a while.
It's been longer now.
But it talked about how families were actually more satisfied with that process, more comfortable with field termination at home. And I think that's a big thing. I always go back to, are we teaching our newest Are we teaching our newest employee? Are you teaching that probationary firefighter, paramedic how to do that appropriately? And I think a lot of times that falls on the organization. That doesn't fall on the hospital.
Yeah.
And I think like presentations like that give you all the tools to show that, studies have shown the family is more comfortable with us working that patient at home, because a lot of family members don't want their family member transported to the hospital, and then they're just going to remember that they passed away at the hospital. And most people don't want that. And that's what that study shows. Most people want to say, hey, I was able to keep them at home. They didn't pass away in a nursing home. They didn't go to a hospital. And I think that still falls back on the organization. I agree with you 100%, Doc. I think that falls back on the organization to take our younger people and our, green EMT paramedic and show them how to do that process and how to talk to the family. This is what's going on. We've been doing CPR and we've been bagging this patient because their heart's not beating. They're not breathing on their own. We're doing everything that the emergency room can do. And, when you get to that 20-minute mark and they see it, a lot of times it is closure for them to be like, they don't want this. So usually when we're ready to stop and we hit that 20-minute mark, the majority of those people, the family members that are on scene, are okay with it.
I think it's harder under certain circumstances. Certainly the patient who's had a good life,
Correct.
is something, and I don't want to put an age on it. What is your life, right? But the person who's had a good life, it's more palatable for family members. The real trouble starts when you have these tragic situations like what recently happened in Avon, where an 18-year-old was riding on a car and fell off and hit his head and was a traumatic cardiac arrest. Those situations are impossible. And you still show the empathy. You still let them see what you're doing. But I think it is really more complicated to do these pre-hospital terminations with the very young, especially children.
Absolutely.
Yes.
Absolutely.
And we do carve out in protocol that some departments, I would say, use this too much, but to say if it's not safe or more appropriate to transport the patient that you are resuscitating,
100%.
It's appropriate to transport them, right?
Yeah.
So we all understand those cases, right?
Yeah.
No, that's what was going to be my lead in there is what if conversely is it's not well received, the family's getting aggravated violence, crazy, and then of course scene safety trumps all, and
transport.
You can grab them and run. All right,
but tell us that when you're coming in, right?
Right,
yes.
Exactly.
Just be forward
for a
with
lot
that.
of reasons.
For lots of reasons,
For lots
so
of
that
reasons.
We can
appropriately receive the patient. We know that this would otherwise meet field death criteria.
Right.
We're going to assess the patient and confirm death,
right.
And then we can be prepared for the onslaught of family at the emergency department.
Yeah.
Before you invite them all back into the room.
Exactly.
Yeah.
Into the department.
You
can
control
control
who's
it.
coming. Right. Security can get involved for everybody's safety, or police department, whoever's necessary there.
And I'll even go as far as to say I've transported a likely brain dead patient out of a very community ED because it was a drive-by gunshot to the head that I transported out just because for our safety at the emergency department.
Right.
I flew a patient out because I was concerned about the safety of the staff at the emergency department.
Yeah. No, patient's not here.
Yep.
Not here.
Yep.
Not here.
Exactly.
That enters, specifically in that scene safety kind of situation where we've grabbed him and run, and then as we're getting our heads settled and we're like, now we either would have not started to work this patient or we would have worked on scene and field terminated on scene. How does that change the dynamics? Now we're in the back of the truck. Can I still call for a field termination even though I'm rolling, or now I've pulled it into drive, I have to go to the hospital and I have to?
That's a really interesting question because we've actually had a couple situations. I don't know if you know about these, but the ER has refused to let them bring the body. And we stopped that.
I was setting that up for actually two different things, but that was one of them, right? So, I guess that the provider, I can still say, hey, we started, but we had to bail due to scene safety. I'm at this point 15, 20 minutes in.
And then the provider needs to recognize that that's why you bailed, and
Correct.
You don't want to continue to do efforts.
Futile resuscitation.
I think it's almost abuse of a body at that point.
Correct.
And so, no, we would field terminate. We would do it appropriately, empathetically, but we would still allow you to bring the body to the emergency department. I think that's more than appropriate.
Now, this kind of starts now butting into interface with the coroner, right? And then that gets a little that gets a little messy. So the other, I started kind of setting that up for the situation of, we were trying to assess this what I believe is a DOA. Everything went messy. We moved to the truck, and it's clearly a DOA, but we're safety, right? We're moving out of here. Now I've got a clearly DOA. I call for appropriate time of death from medical control. Now this gets messy for the coroner, right? Because I've moved a body, and I know that at the region we were kind of working through some restructuring on how, in those exceedingly rare, but they'll happen, right? They'll happen because of the nature of our business, right? Any thoughts on that whole thing? Let's say we had to move them, or the hospital still has to take the.
We still have to take them.
We still have to. Them. We can't sit on the side of the road. I mean, this is what I needed to get to. Is we can't sit on the side of the road with a body in the truck for 4 hours waiting for the coroner, right?
Yeah.
Because we still need a destination.
Yep. I think that we're not going to like it at the hospital or in the ER. We're going to do it. We'll take the body.
Yeah.
I think it's important to realize that once we've declared a body dead, questioning whether or not it's going to be a coroner's case, at least in the state of Ohio, is to not remove any devices, don't remove IV access, leave the body as it is. We're not going to do anything.
Advanced airways.
Yeah, so advanced airways stay in, IV stay in. If the equipment's attached to the patient, leave it on. You can take Luke's device off, those types of things. You can disconnect your bag from the ET tube, but all that stuff's going to stay in place. So that way, until the body's been released by the coroner, that they can then evaluate if there is concern that there's something at play that they want to do an investigation.
Correct.
I think the other thing too here is, how many agencies have a relationship with their coroner in their county? So, right, I'm going to open Pandora's box here.
Indeed, right.
We do. We have a great relationship with our coroner in.
I don't think that's Pandora's box. I think you should have a relationship, right? I think you should invite them out.
Correct.
And have them do training with you guys, like coroner's office. How do you want?
How do you want us to? Yeah, exactly.
In fact, just to reiterate what you're just saying here, I go to a lot of counties, and I was out in Erie County. And there was this whole confusion because they didn't understand why you would have to call medical direction to get a time of death. And it's not something they were used to. Yeah. And we've only been out in Erie County for, maybe...
a year and a half?
Oh, no, it's been longer. Maybe 4 or 5 years.
Yeah.
And I kept writing them, guys, you gotta call med control to get a time of death. And, each little department... And then some bigger departments kind of were pushing back. And nowhere was it more important to get the coroner involved because it was the coroner because they ultimately have the control of a deceased, right? But it wasn't the control that I was comfortable with. Right. So we brought the coroner in to their regional EMS meeting, and he got it. So having a relationship with a coroner, if you don't have that in your department areas, I really stress that you need to get the coroner involved so that we're all playing in the same sandbox, on the same page, so that we don't have any kind of disturbances of what could be crime scenes.
Right. And they'll be ecstatic to come out. Most of them are to come out.
Oh, yeah.
Generally, yes.
Yeah. We invited ours out. We had our coroner in our county at a local chiefs meeting, and that's where you talk a lot about those anomalies, right? Because that doesn't happen a lot. Like, hey, we're going to transport that body to the emergency room. What ifs, this and that, and all our coroner said, what, if you get something weird like that, just call me.
Yeah.
That's all. He's like,
we'll sort it out.
That's fine. Just call me, and then that relationship is huge. We had some They needed certain information that was not being provided, so we helped design a form together that their office pays for and hands to all of us, and it has all those things on it. It's super simple, but having a good relationship ironed out 99% of those problems. 99% of the questions were answered, and then when you walked away, it's running a lot smoother now. So it's just engaging them, having a conversation, and that's where you can also say, well, this is what our protocol says.
Right.
This is what our physician's looking for. What are you looking for? How do we mesh this together? How does it work?
Right.
And we've had a great relationship with ours. I'm very happy with Dr. D'Amico.
Dr. D'Amico's great. And Ashland County, the doc down there, she actually worked with EMS to make a form just like that. Yeah. And she was so excited to come to our EMS regional meeting.
Yeah, and a lot of times you'll end up getting them. We've hosted them for CE.
Right.
And they'll teach some pretty,
yeah.
All the things that we're talking about today is kind of interesting.
I got to tell you, those are like some really gross lectures. They seem to just love showing it. But you know what? It's reminding me of something. You remember calling the DOA from the door we talked about early on in this podcast?
Okay.
The one coroner, Bob, what was Bob's last name? Coleman. Bob Coleman, who was one of our EMS medical directors and an ER doc. Yeah. He had
your director.
He was our. Yeah.
He had a great lecture about coroners, and one thing he said is you got to look at the whole room, because he had one that they called natural causes, and when they went to the other side of the bed, the coroner found a gun on the side of their head. Or is this your lecture?
This is my lecture from last year.
Yeah.
I'm sorry, that was Portage County.
Yeah, Portage County. No, while I'm talking about this, I just remembered.
There's a big sign from.
You had another one where the guy had a rope around his neck.
Yeah.
And everybody missed the rope.
Natural causes, right?
Arrow sign with clue.
No, but Bob Coleman did write lectures like that.
He did, absolutely.
I do remember your lecture. It was fantastic. But it tells you gotta take in the whole scene.
The whole picture. Yeah.
Whether you're calling in a time of death or you're reporting a body, please look at your patient and touch your patient.
Yes.
Yeah. I mean, we stressed this earlier. By definition, these are not hurry up cases.
Right.
Take a minute, get it right. I mean, it is super important.